Happy to see so many of you back tonight. So we're happy to have Dr. Tim Jessick with us tonight. Dr. Tim is with Aurora St. Luke's Medical Center and with the West Dallas Medical Center, and is a palliative care and hospice physician with those two organizations. So he's going to talk to us tonight about palliative care and hospice care. He's going to discuss some of the myths and facts and answer your questions about healthcare at the end of life. So please join me in welcoming Dr. Tim Jessick. Thank you.
So if about 30 of you leave because you say, oh, well, we're here just to see Dr. Rapenchek, I understand. So if you have to go, you can go. Well, thank you so much for inviting me, or allowing me to invite myself maybe to come. The seminar we gave probably about 6 months ago at St. Dominic went so well. It was so well received. It just made sense that a lot of folks have, thank you. A lot of folks had questions out there, and so we wanted to make sure that the more people that had this information, the better. So this is really all for you. If you have questions along the way, please stop me. If you can't hear me because I'm dropping the mic, let me know. I was doing yard work all day yesterday, so my arms are a little tired, so they might fall a little bit. So really kind of what I wanted to do tonight is in a little bit define a little bit about what palliative medicine is and isn't, because not a lot of folks may know about that. I want to talk a little bit about what usual medical care might look like versus more of a palliative approach versus a hospice approach, and I'll kind of explain what that means. We'll look at some very specific medical conditions, and I picked just a couple. You know, if there's something that folks want to talk about, a different condition, we can discuss that as well. But you know, how does a different approach apply to these different processes? And I really want to talk about how healthcare decisions, as tough as they are and as complicated as they are even more complicated for those of faith, for Catholics, Lutherans, and others. And we'll kind of talk about that too. Okay, so a question for you all. So everyone probably came and had a big dinner with family today before coming tonight, right? Sat around the kitchen table and visited and talked. By a show of hands, how many folks talked about death and dying and chronic illnesses? One, two, a couple. You did talk about this? So you visited a family member, and you started talking about it because of that. Good. And a couple other folks said they talked about it, but nobody else? You didn't talk about the weather and death and dying today? So why is that? You know, why as a society do we not talk about death and dying and illnesses and things like that? What do you think? We ignore it because we don't want to face it? Absolutely. Why waste your time talking about death and dying? It's inevitable like taxes, right? What do you mean why waste your time? You have some things to finish, don't know when it's going to happen, so we'll not talk about it right now, right? Okay. Yeah. That's something you bring up on a normal basis. Okay. Why else? Why else don't we talk about it? Yeah.
We go to life as like a box of chocolates, and you never know what you're going to get until it's there.
So
you could end up getting hit on the road, or you could end up with a chronic illness that spans out, or you could work with something that might be cured, or you can end up with something where there's no change.
Absolutely. So there's a lot of unknowns. You don't know what's going to go on. But does that prevent us from talking about it?
Don't know what to talk about.
Don't know what to talk about. Good. Well, hopefully after today we'll know what to talk about. Why else? Any other reasons why we don't talk about serious illnesses and things? It's depressing. Yeah, it upsets your kids to talk about it. What about you when you talk about it? Doesn't bother you. Why don't you think your kids want to hear about you talking about death and dying? They don't want to get rid of you. Good. That's a good thing. So does that mean if they do want to talk about it, they want to get rid of other folks? Is that? No. So we're going to talk about that a little bit, but it's a very common thing that this is not something we really talk about well. We should, even though it's something that's going to be inevitable and it's going to happen, but we don't talk about it really well. So just a little bit about palliative medicine, and really just a little bit about my story. I actually am a family physician. I've been a family doc for 15 years. And way back when I was doing my training up north in Wausau, I remember as a resident working with probably one of the smartest internal medicine docs I've ever met. Very, very bright. He knew everything. But we had a sick patient in the ICU, and we really needed to have a conversation with the patient and the family about what's going on. So I'm all ready to go in there with him and saying, boy, he's just going to be brilliant and he's going to be awesome and I'll learn so much from him. And he said, Jessick, go and talk to the family. I said, okay, well, when are we going? He says, no, you go talk to them. I have to do something else. So I did. A little nervous, but I did. But it was the first time that I really experienced how physicians aren't really good at talking about this stuff either. Okay? It really surprised me, but it's not the first time that I've seen that. The second big influence on me, kind of the same year up in Wausau again, was seeing a couple in the hospital. I think actually it was in Marshfield, so Catholic hospital. I saw an older couple. I think one of them probably was a farmer by the way he was dressed. But here they are in this huge hospital. In my mind, they were just so overwhelmed. Probably overwhelmed because it was a little bit bigger city than they were used to because there's so many small towns up there. You could tell that he was a little bit on the sick side just from the look of it. But the fear in his eyes, the fear in his wife's eyes sitting right next to him, just being overwhelmed. What's going on? What are we doing here? What's going to happen next? Really impressed upon me how complicated healthcare is, how complicated being sick is, and how tough it is. So partly because of that, the idea of, well, how can we help these folks where sometimes they don't have help really came in. And that's really where palliative medicine comes in. Palliative medicine is a specialty where I work primarily in a hospital, sometimes in outpatient, but mostly in a hospital doing consults. But I see patients and families that have chronic, serious, or life-limiting illnesses. So I see them along with the hospitalist or the primary care doc or the other specialists. And that's my job. Big part of what I do is talk. I go in, I learn as much as I can about the patient as far as the medical record and scans and x-rays and labs and talk to the docs and the nurses. So I have a pretty good idea what's going on medically wise with the patient. Then my job is to go talk to the patient and family. And it's a fantastic job. I get to go meet them, see what makes them tick, what matters to them, what is their understanding as far as what's going on as far as their illness. And then based on this conversation and giving information, we figure out what kind of goals of care make sense. What care from that point on makes sense and doesn't make sense. So unfortunately, you have to have a specialty to do this because I think the primary care docs really kind of did this in the past. But that's really what palliative medicine is. So communication is a big part of what I do, really discussing goals of care. You're going to hear that phrase again and again and again. What are the goals of care? We do a lot of symptom management and things like that. The other part of what I do when I do a patient and family evaluation is a spiritual screening. Docs and nurses just don't do that a whole lot. It's almost like it's taboo now in healthcare, even in hospitals. So that's a big part of what I do. The other big part that I found out a long time ago is that patients and families kind of want to know what's going on. Would you want to know what's going on if you're in the hospital as far as your health or health of a family member? Yeah, I would hope so. So the Wisconsin Catholic Conference back in May 2013 produced a pamphlet, I guess I'd call it, called Now at the Hour of Our Death. Has anyone ever seen that before? Of course you saw it. So a pastoral letter from the Roman Catholic bishops of Wisconsin on end-of-life decisions. And at the time, Pope John Paul really was quoted as saying, the temptation is becoming ever stronger to take possession of death by anticipating its arrival, as though we were masters of our own lives or the lives of others. I see that a lot, where we really think we know what's going on with folks. You know, medicine's really good. Scans and tests are really good. We don't always know exactly what's going on or how things are going to work out. And I think that's what then Pope John Paul really was referring to. The other part of the Catholic conference is some recurring themes. You see over and over again that life is sacred, and they emphasize how life is sacred. They also mention how we are entrusted with the responsibility to serve as stewards of our own lives and to respect and protect human life at all its stages. We think so much upstream as far as protecting life and babies. The end of life is just as important. They also mention how the church has never taught that the faithful are obliged to use all available means to sustain life. So some questions might come up later, and we'll talk about this a little bit more, but that statement I think is huge. So I'm going to repeat it. The church has never taught that the faithful are obliged to use all available means to sustain life. So just because we have treatments, just because we have machines, doesn't mean you have to use them. In a lot of cases, they'll make sense. You know, using dialysis, using a breathing machine, doing surgery, for a lot of folks, saves their lives. It makes perfect sense. But if the goals don't go along with that, and if it doesn't make sense to be doing something really, really aggressive like that, you don't have to do it. And that's not considered euthanasia. That's not considered killing your loved one. Does that make sense? Yes? Great question. So the difference between sustaining a life just for sustaining a life and quality of life, that's really a personal decision. That's where the goals of care, the patient-centered care really comes in. It's more difficult when you're talking about mom or dad, and mom and dad can't answer that for you, but that will be a question we'll bring up. You know, tell me what's been going on with mom over the last 3 months. I know she can't tell us anything because of her dementia, but how has she been doing overall? How has she been functioning? I know she's not talking now because of her dementia, but you know, does she seem to like going to bingo? Oh yeah, she loves bingo. She gets this big smile on her face, and she never wins, but she loves going every single time. That tells me their quality might be pretty good. If, however, on the flip side, you say, yeah, you know, mom just hasn't been doing really well. You know, with her, ever since she had her cancer, she's in pain all the time. She's in bed quite a bit of the time. She has these sores on her butt, and she's hurting all the time. That definitely comes into play. You're welcome. So I think that's also where the discussion, we'll talk a little bit more later about ordinary and extraordinary means. Now the church will say, and rightly so, that we need to offer folks food and water. That's just basic care, right? Even in the hospital setting, even if it means artificial nutrition through a tube or IV fluids, those are things we should normally offer in most circumstances. That's ordinary care. If, however, by giving fluids through an IV or food through a tube, it's causing harm or causing problems, that's when they call it extraordinary means, and you don't have to do that. Okay? So ordinary means, yes, let's offer food and water to the best of our ability. But if it's causing suffering, causing problems, and it's extraordinary, you don't have to do that. Okay? Does that kind of make sense? Kinda? The Catholic Conference also talked about advanced care planning. They talk about advanced care planning and documents that you heard about a little bit last week and will again tomorrow is really a gift to your family. Okay? So even if your kids don't want to talk about all this, to say, listen, I need to appoint a decision maker in case I can't make my own decisions, and you need to know what I want and don't want. What a huge gift for your family so they know. If we don't do that, if I don't do that, and on my way home back to Menominee Falls tonight, I get hit by a car and I can't answer things. If I don't have paperwork done, at least in the state of Wisconsin, that decision-making ability does not automatically go to my wife. We don't have that in the state of Wisconsin. You have to have the power of attorney paperwork. Does everyone know what I mean? Power of attorney paperwork? So you have to get that done. Okay? It's a legal matter. It's a Wisconsin statute. You know, in some states, it automatically goes to your spouse or to your kids as far as decision making. Here in Wisconsin, when I have to go to the ICU to have a big old family meeting because we don't know what's going on, I have to bring all 10 family members into the room, and we have to get 10 out of 10 saying this is what we should do or shouldn't do. It's very, very tough.
Yes.
Could you step back one, and when you said power of attorney,
Yes.
could that be stated as power of attorney for health care?
Yes.
When I'm talking about power of attorney, at least for this part, it's power of attorney for health care, so for health care matters. I don't care about the power of attorney for financial matters. Unless I'm in the will, then I care. Otherwise, the financial part's important, but all I'm talking about for power of attorney is the healthcare part. Okay? Are you putting me in your will? Yes. The other part of the Catholic conference is the details to address in preparation for time when death is imminent. So these are the kind of conversations we should be having with our loved ones. You know, what kind of extraordinary means would you want to use to sustain life? Some folks I talk to say, you keep me alive no matter what. Being alive is the most important part to me. Okay, good. We know that. Make sure your family members know that. Other folks say, listen, I've been suffering so much, I can't keep going on like this. If it gets so bad where I can't talk to my family anymore, that's not how I want to live. I don't want to come off life support. You can talk about places where you want to spend your last days. Boy, I'd really want to be at home, or I don't want to burden my family at home if I have to go to a facility or a hospice facility. That's where I like to be. You can talk about CPR, and also they discuss organ donation. So this is all part of this document I mentioned. So again, palliative medicine, really works through all these. We work on having goals of care discussions. My main job is to be as patient-centered and family-centered as possible. Okay? It's probably not even patient-centered, it's person-centered. How can I get to know folks as a person, what matters to them, who they are, what they understand as far as what's going on. Symptom management, pain management, nausea management is a big part of what we do. The goals of care discussions, here we go again. Sitting down and figuring out what matters to folks is huge. And then the advance directives, of course. So Sister Carol Keehan, who is the CEO of the Catholic Health Ministry of the U.S., which I believe is probably the largest health system in the country, she defined palliative care as an expression of our mission of the Catholic Health Ministry. She says palliative care really promotes dignity, patient and family-centered, compassionate care based on patient values and wishes. It's a good thing, right? Patient's values and wishes. When's the last time folks had their values and wishes addressed in the hospital? Maybe kind of, to a small degree. Has anyone had their values and wishes addressed at a hospital? Really? Okay. We'll work on that, all right? Palliative care really attends to the whole person. Addresses the comprehensive needs of the seriously ill patient, so including pain, symptom management, psychosocial issues, emotional support, and spiritual support. It cares for the vulnerable, so folks that can't care for themselves or answer for themselves. So an interdisciplinary team coordinates care so seriously ill patients do not have to navigate an unfamiliar, fragmented delivery system on their own. Kind of like that farmer and his wife. So I'm going to, just to kind of point this out, I'm going to talk about really 3 different kinds of care. Really kind of usual, typical care, more of a palliative approach, and then a hospice approach. The more I've thought about these 3 different approaches, they're almost 3 different ways of treating someone. Hopefully we'll get to a point, and not in the too far near future, where we have kind of usual medical care, kind of way we've always done things. I'm hoping at some point the new usual medical care is really a combination of the palliative part and usual medical care, meaning I'm hoping that care from now on is always patient-centered, is always goal-driven based on what the patient and family want to do, okay? So I think we can get there, but we're not quite. So when we're talking about usual medical care, we're talking about ICU care. If I get into an accident, of course, send me to the ICU. If I need a surgery done to save my life, I want to have that surgery. It includes procedures and testing. It includes different treatments and, of course, resuscitation and things like that. So in my mind, that's really usual medical care. So what about palliative care? How is that different? Well, the care is driven by what? Goals, right? And whose goals? Patients. A patient or a family, depending on who they are. So for palliative care, it might be the same thing we just looked at. It might include ICU care, it might include resuscitation and surgery and all those different treatments. If that's what makes sense, if that's the goal for the patient, if those are their wishes, then that's what we should be doing. At the same time that we do usual care, we always want to focus on comfort. There's no reason why you have to be in the ICU and have pain, or be thrown up, or feeling sick, okay? So of course, it may include the usual care. There might be limits. And I see a lot of folks that come in and say, well, I really kind of want usual medical care, but you know, if I get to the point where my heart stops again, like it did last year, I don't want to go through that CPR stuff, but I want everything else. Okay, well, this is the limit that we're going to set. Or some folks say, man, I've had 3 surgeries now for my diabetic leg. I don't want to go through another surgery. It was just too hard on me. Okay, well, maybe that's a limit we're not going to go past. The bigger part is avoiding non-beneficial care or treatment. It kind of sounds silly. Well, why would you provide a treatment that's not beneficial? We kind of do that all the time. And there's a lot of treatments out there that may or may not help, but we say, hey, let's go for it. Let's just try it to see how it's going to work. Cancer care is probably a very, very good example. You know, cancer is so tough on folks that once you get to the 3rd, 4th, 5th line of treatment, the hope for any benefit is a lot less, but we do it because we want that chance. So this happens sometimes. A hospice care or hospice approach is really totally focused on comfort, and preferably comfort in the home. These are for folks saying, I'm tired of going to the hospital, I want to be comfortable, I know my time is limited, I want to spend my time with my family at home, I want to be as comfortable as possible. This is where hospice really comes in. So this is where we're truly looking at quality of life, not quantity of life. So really what I want to do is go through 4 different conditions and see what these different approaches look like. So I just pick congestive heart failure, heart disease, chronic obstructive pulmonary disease or lung disease, dementia, and cancer. And again, if somebody wants to talk about a different disease process, we can. So what's usual care for heart failure? So that's for someone that has a bad heart, where the heart's not pumping the way it should. So congestive heart failure, heart failure. Well, if you go to St. Luke's in Milwaukee, man, you can get a heart transplant if you need that. You can get catheterizations. You can get bypass surgeries, all these really, really good treatments, and they're fantastic. You know, folks that have gone through all this will go through heart rehab, where you do some exercises to help your heart out, and there's tons of medications now that are available for them. So that's kind of usual medical care for hearts, and we're very fortunate, in especially southeast Wisconsin, that you have access to all of those. Well, what about palliative care approach? How is that different? So what is the care based on? Goals. Whose goals? Patient and family, right. Well, I'll do this a couple more times so get a chance to participate. So a palliative care approach might be usual care. It might be surgeries, it might be heart transplants, whatever makes sense for that patient and for their care. We still want to use the medications for the heart. If procedures make sense, we're going to do that. We're still going to encourage heart exercise. Maybe we'll try a couple different medications for breathing. Maybe we'll look at all the medications and say, wow, you're on these great medications to make your heart pump as well as it can, but you're still short of breath and we can't fix that anymore. Maybe a low dose of Vicodin or morphine or some sort of narcotic might help your breathing while you're gardening and doing normal things. So maybe we'll look at a couple different medications for symptoms. For some folks, they've had heart failure problems so many times. They say, hey doc, this is my 3rd time in the last 2.5 months that I've come in for the same problem. I'm not going to go through any more surgery, or I can't go through more surgery. They don't help me anymore. I come in for a couple of days and then I go back home and I don't feel much better. I don't think I want to come back to the hospital anymore. Okay, let's talk about that. So those might be the goals for some folks. If that's the case, more of a home care approach would make sense for them. So how can we help you out in the home? They still might want, you know, antibiotics for pneumonia, but they might not want the aggressive hospital type of care. So again, the hospice care, based on the goals, if they say, I just want to stay at home, I don't want to do the hospital thing anymore, well, adding hospice where they can really work on the breathing, where they can help with function as much as possible. That might make most sense. Again, quality versus quantity of life. So can folks kind of see the different kinds of care potentially? It's not cut and dried. It's not one or the other. It's not an option. I want B today. I ate at Culver's today, and there's a lot of options on there. That's not the kind of options we're talking about. What about lung disease, COPD? Well, usual care is using inhalers. Boy, if you're at St. Luke's, you can get lung transplants and things like that. Nebulizers, boy, we want to work on exercise to make sure your lungs are working as well as they can. Usual care. And of course, we want folks to stop smoking. Palliative care approach, again, based on goals, based on what's important for the patient and patient-centered, Might be all the same treatments. You still use the inhalers. Stop smoking. Let's get you as strong as possible. So do some lung rehab. Here also, some lung patients say, I keep having these flare-ups of my lung disease. They never find anything. They do all these x-rays. And there's nothing they really can do. And if I can get by with antibiotics with my doc in the office, that's what I want to do. Some folks get to the point where I just don't want to come back to the hospital. This is where setting those limits are important. This is also for some lung disease patients, if they're using all the right medications, maybe a low dose of oxycodone or Vicodin will help their breathing. Okay? So those medications aren't just for pain anymore. They really do help breathing. So what about a hospice approach? Again, it's more home-based, comfort-focused, not coming back to the hospital. This is also where we start talking about using stronger medications for breathing. Folks that have lung problems really have a hard time catching their breath. And it's very, very scary for folks. Boy, I just can't catch my air. It feels like someone's sitting on me. It's a very scary thing. This is where we start having conversations with folks saying, listen, the low-dose oxycodone pills you're taking work to a degree. We might need to step that up. We might need to start increasing those doses. By doing that, you might get a little bit more sleepy. So we need to talk about that. And driving maybe not a good idea anymore. But those are the type of conversations we might need to have. So, talked about a couple different illnesses already. And as you can see, the options really kind of depend on where folks are, what's important to them, where they are in their life and in their mind, right? So, even though my daughter gets mad at me for saying that, she always giggles when I talk about how on April 5th, 1722, explorers discovered Keister Island. And I'm a 5-year-old at heart, I guess. So what about dementia? So kind of the same approach. Usual care for dementia. Everyone here has seen somebody with dementia, family member or a friend or something. Yeah. Dementia is a terrible, terrible disease. With the other conditions I talked about, it's more of a physical problem. With dementia, it's both. It's physical and mental. Usually at first we see folks whose memories start to get bad. Then they start forgetting people. Then the physical part starts happening where they can't swallow very well, or can't move around as well. So for the poor patients, they kind of go through a double whammy where they lose this, and at some point they lose the muscle part. It's just really tough on them, and that makes it really tough on family members. So usual care for dementia, again, initially you want them to see a neurologist or a geriatrician to see what kind of medications may or may not work. We'll have them go to memory clinics where they can actually go and work on their memory, work on memory exercises. There's some medications that'll work, not a lot, but those are things that we'll look at. Usually earlier on for dementia, they can be independent. They can live at home. You know, they can kind of compensate for not remembering things by writing notes down, little sticky notes and things. Palliative care approach, again, it might be all those things as before. This is, by the time I start seeing folks for dementia, usually their dementia is getting a little worse. Their function isn't as good. They're forgetting a lot of different things. You know, sometimes leaving the stove on or something like that where danger might be an issue. Part of my job is not to have a better crystal ball than anybody else's to predict what's going to happen, but we see this happening so much we start talking about it. Now, let's get rid of those rugs in the house because, you know, falling might be an issue. We'll talk about the memory loss and say, you know, it might be time to be looking at other facilities. Being at home alone probably isn't going to work very well. It's not going to be safe anymore. I mentioned the muscle problems. Swallowing gets to be a big issue for dementia patients. At some point, they just don't swallow as well. So all of a sudden, the food they're eating goes down the wrong tube. It's what we call aspiration pneumonia. That is something that will happen again and again and again. So those are the type of things we can talk to families about as well. You know, usual care for an aspiration pneumonia is to bring someone to the hospital, get the x-ray, yep, there's a pneumonia here, do a swallow test, yep, swallowing is an issue, use antibiotics, and a couple of days later they can go home. But as I said, this thing can happen again and again and again. And part of our job as we talk about goals is to tell folks, hey, this is going to be a recurrent problem. These falls are going to happen again and again just because they're getting weaker. Let's talk about this a little bit. You know, do we need to look at a different facility? Does walking even make sense anymore? Maybe we should be looking at canes and things like that, or a walker or something like that. But as we start talking about the hospice approach for some folks, this is also where we say, well, you know, Dad's going to keep having these problems. How has their quality been? How are things in general? How's that bed sore that we saw last time they were in the hospital? And for some folks, they say, boy, that quality is so poor. They just seem miserable all the time. They're not interacting anymore. Boy, I didn't realize that not sending Dad back to the hospital is even an option. So for some folks, that does make sense. For some, it doesn't. That's where having that conversation, having that goals of care discussion makes sense. Any questions about dementia? Yes?
You mentioned all three of these situations. You had no returns to the hospital except for emergencies. Prior to that, you said they didn't want to return to the hospital. So what is the difference between returning to the hospital or returning to the hospital for emergency?
Great question. So the question was, I mentioned on there, if someone says, I don't want to go back to the hospital if I don't have to. But I had a slide on there saying, but maybe only for emergencies. Even for folks that say, I want to be on hospice, I want to stay at home, certain occurrences happen where we have to at least consider going back in. Let's say a hospice patient that's clear, I want to stay home, that falls and hurts their hip. Sometimes for emergencies like that, we say, listen, we know you don't want to go to the hospital, but we kind of need to know if you broke your hip or not. Because based on your goals and how you've been doing, maybe repairing that hip in the hospital actually does make sense, so you're not in so much pain, or so you can still walk around a little bit versus being in the bed for the rest of your life. So there's certain circumstances like that where I think going to the hospital at least for an evaluation would make sense. Okay?
And with the heart problems, they're going to return to the hospital for some non-heart problem.
Right, and I'm thinking more falls with that. That's where we'll see folks come in. So even they say, boy, I don't want to go back to the hospital for heart failure or shortness of breath or anything like that. You know, if they fall and hurt a hip where we need that x-ray, sometimes that can be done in the clinic. But it doesn't necessarily mean that even though they go to the emergency department that they have to stay. Let's just get an x-ray, and if it's normal, we'll send home and just focus more on the pain part. Okay, so there's not a lot of emergencies like that, but it happens once in a while. And to be honest, that conversation maybe is a little bit more for family. Because as we're talking about their loved one who can't kind of respond for us, if they didn't have plans set up ahead of time, if they really didn't tell their loved ones, boy, if I get to this point, I don't want to go back to the hospital. Don't send me there. You know, I want to die at home. And by the way, if you send me back to the hospital and I die, I'm going to haunt you for the rest of my life type of thing, right? Having those conversations will help family members, but a lot of times I just have that conversation because it's so hard on family members saying, I'm not going to send Dad back to the hospital again. I'm just a terrible child. How could it be so mean to my dad? And by the way, I kind of wish he would have told me he loved me before his dementia got so bad, and that's kind of why I'm holding on to all this, or whatever it is. So sometimes it's just saying, hey, things aren't black and white. This is America. You can do whatever you want to do, even if you're on hospice, okay? But at least it's not black and white to some family members. Thank you for asking. That's a great question. I mean, cancer care these days is really, really good. You know, throughout the entire state, we have some wonderful cancer centers that are really good at diagnosing cancers, especially earlier on, and then treating and doing surgeries and things. You know, thank goodness. So usual care for cancer would be surgeries if needed, chemotherapy, radiation therapy, a lot of different things. A palliative care approach, again, depends on what? Goals, okay? Now, I keep saying goals and I kind of keep saying what patients want and don't want. Part of that's our job. We have to give folks information. This is what's going on. This is your prognosis. This is what's possible and not possible, right? Some of that's on us. But after we give you that information and kind of figure out what matters to you, patient-centered care, then we can come up with a goal of care that makes most sense for you. But it's a team approach. So a palliative care approach to cancer might be all those things again: surgery, chemotherapy, radiation therapy. Remember, comfort always. You don't have to be on hospice to have comfort and have your pain controlled. So even if cure is not an option, those other things really may help. Even for folks that say, I'm done with chemotherapy, I'm done with all this treatment, if they come in kind of an emergency basis and they say, I want hospice, but now we know they have cancer that's spread to the bone, doing radiation therapy to the bone really might be the best pain relief they can have. So that might be treatment that otherwise they'd said, I don't want treatment. This really might help their pain. So there's certain circumstances they'll do things like that. Again, really good goals of care discussions. And then again, the question is, does returning to the hospital make sense? But again, that's based on these conversations. Hospice care for cancer, comfort always. Quality versus quantity, probably at home. A lot of times folks, especially if their pain is so bad from cancer, they need to be at a facility, hospice facility, or a nursing home with hospice, just because they really need more aggressive care. So does that kind of give you an idea of kind of the different options that are out there for folks? Now, I didn't say choices, right? I didn't say choices where you can kind of pick and choose what you want. These are really options based on information from our side and then having good discussions, okay? So what is an advance directive? I mentioned that a couple different times. You know, really an advance directive is a plan. Officially, it's a document, okay? This is the way that you can express your wishes and pick who you want to make decisions for you. This is really not about a document. You'll hear this tomorrow night with Dr. Rapenchek, too. Brilliant, brilliant bioethicist, by the way, with a cool name, I heard from somebody tonight. This is all about the conversation. We'll talk about documents, but having the conversation, picking someone to help make decisions for you that you trust. If you pick your spouse and your spouse can't follow your wishes, then pick somebody else, okay? With all due respect to your spouse, you need somebody that's going to be able to follow your wishes, all right? But it's a plan. It's kind of planning for down the road. So there's different kind of advanced directives for health care. There's the power of attorney for health care, Aurora long form we call it, Wisconsin state form. Some people see what's called a 5 wishes. I'm not going to go through all of these, just know that, you know, a lot of them are just legal documents. This is that, what we call the Aurora form or the living will. It's a long form, but it gives you a chance to pick decision makers. It gives you an area that if you say, boy, I know for sure that I do not ever want to be brought back from the dead. I don't want CPR. I don't want to be in a breathing machine. Filling out this page for this living will help with that. You can initial it. You tell your decision maker, I don't want to ever be resuscitated because I saw mom go through that and I know my heart's really bad. This is the way that you can initial and have this on an official legal document. 5 wishes form is available in the state. So, you know, what have the popes, what have other folks said about kind of about this end of life stuff? Well, at the times, Pope John Paul II, this is in the address to the participants in the 19th International Conference, said, particularly in the stages of illness, when proportionate and effective treatment is no longer possible, while it is necessary to avoid every kind of persistent or aggressive treatment, methods of palliative care are required. Okay? So even here, at the time, Pope John Paul is saying, if you're getting towards the end, you don't have to go through a bunch of different treatments. He also mentions to seek to make suffering more bearable in the final stages of illness and to ensure that the patient is supported and accompanied in his or her ordeal. Folks shouldn't have to go through this stuff alone, and we see that way too often. So he goes on saying, even when medical treatment is unable to defeat a serious pathology, all its possibilities are directed to the alleviation of suffering. Working enthusiastically to help the patient in every situation means being aware of the inalienable dignity of every human being, even in the extreme conditions of terminal illness. Christians recognize this devotion as a fundamental dimension of their vocation. Indeed, in carrying out this task, they know they are caring for Christ himself. So even Pope Benedict had a comment. This is from World Day of the Sick. It is necessary to stress once again the need for more palliative care centers which provide integral care, offering the sick the human assistance and spiritual accompaniment they need. This is a right belonging to every human being, one which we must all be committed to defend. At the very end, he says, many such individuals, healthcare professionals, Pastoral agents and volunteers and institutions throughout the world are tirelessly serving the sick in hospitals and palliative care units on city streets and housing projects and parishes. Emphasis added. So even for the popes, this was a big issue, and thank goodness they were able to address this way back when. So just in the last couple of minutes, so why are these advance directives important? Here's a case, and I've seen several of these cases. 85-year-old gentleman comes in with advanced dementia. Frequent admissions for aspiration pneumonia. So again, swallowing is very poor. So food goes down the wrong tube, saliva goes down the wrong tube, causing pneumonia, and they come in with dehydration. So the usual kind of typical medical care is, oh, well, I'm a doctor, I can figure this out. Yep, they've been having problems with choking, we'll get an x-ray, yes, it's a pneumonia, here's the antibiotics, we can treat this, and oh, they're dehydrated too, let's do IV fluids, we can fix this too, he'll be out of the hospital in 4 days. Perfectly fine. Folks in the emergency department do this every single day. I'm kind of a why guy. So why is he having problems with swallowing? Well, clearly it must be from the dementia. And as you talk to family, yeah, he's coughing a lot. Every time he has a drink of water, he starts coughing. Oh, okay. Well, maybe we do need a swallow evaluation to see what's going on. Well, why is he dehydrated? Well, when you talk to family, they say, well, he's not eating and drinking very well. It takes him forever to eat a meal. And when he does, he coughs and chokes and things. And he just doesn't drink very well anymore. Well, we can treat dehydration. But if this is all because the dementia is getting worse, it's our job to say, this is something we can treat for a short period of time, but the dehydration, the pneumonia is going to happen again and again. Nothing wrong with the IV fluids, nothing wrong with antibiotics or the hospital, but folks just need to know this is something that might happen again, okay? My big question also is, does this patient have an advance directive? Were they able to, at some point before they got bad, kind of tell family members, listen, I want to live for the sake of living, and I want to watch every Brewer game I possibly can. And if they're losing like they are right now, I want to be really confused during that time, but I want to be alive no matter what, okay? Good, we have some direction as far as what they want. Other folks might say, I don't want to keep coming back to the hospital, okay? So here's another case, a 69-year-old woman with end-stage COPD, really bad lung disease, something we can't fix. Several admissions to the hospital for shortness of breath. Very common. It doesn't take very much to put someone's lung disease over the top. Could be the flu, could be a cold, could be allergies. But it's very tough for folks. They really struggle to breathe. So the patient says, I'm tired of coming back to the hospital. And we talk about that. Well, are you using your inhalers? Are you using your nebulizers? No, I don't use those anymore. Well, maybe you should. That might help you out a little bit, okay? Are you doing some of the usual typical things? Oh, not really. Are you still smoking? Well, yeah. Okay, that's probably not a good thing. Maybe you should stop smoking. So you go through all those type of things, but if we can't fix the problem, if you use medications and narcotics to help their breathing, they're still suffering, still having a hard time, well, okay, maybe not coming back to the hospital does make sense. Let's talk about that a little bit more. Is that possible? What are we going to do if you get short of breath at home? So here also I want to know, does this patient have an advance directive on file? This is someone that really bad lung disease, which could end up going on the ventilator that night. We need to kind of know what their wishes are and who their decision makers are. And what are the goals of care. So if you can kind of look at this black diagram, this is really somebody putting along, kind of staying at baseline. All of a sudden they hit a part here where they have a pneumonia. They come into the hospital. Kind of have a drop off of function. As you see, they get antibiotics, they go to the hospital, they bounce back up, but they never get back to that baseline, to the top line, right? It's pretty normal. You're doing fine, take a little bit of hit, get treatment, bounce back, but never quite to where you were before. Then you go along for a couple months, or maybe even a couple years, all of a sudden you fall and break a hip, have a little dip. Bounce back, but not quite to where you were before. So the jagged line just kind of shows how things progress. The sooner we can talk to folks in here, the better, because once they get here, this is death. This is where folks die. So do you see how the pattern kind of works? Folks keep having these problems, more so towards the end of life. We want to catch people and talk to them up here before they get down there. So, really in summary, what the Catholic Church teaches us is, life is sacred. I mentioned that before. And that's really how we should be approaching healthcare and life in general. But your healthcare really depends on a couple of different things. Goals of care. Having a good understanding of what's going on, and based on your understanding of the disease process, these are my goals. This is what I want to do. This is what's important to me. A lot of it deals with function. What does function mean to folks when you hear that? What am I able to do? Walking, talking, doing things like that, right? What else? Being with family. For some folks, if they can't function by talking to people, that's not worth living. Other folks will say, I don't want my family around me. Just give me a good book and I'll be happy, right? Kind of depends on who they are. Your healthcare really depends on burdens. For some folks say, hey, I'm used to chronic pain, it's not a big deal. Other folks say, I can't handle this pain anymore. I'm hurting all the time, I'm miserable. Those burdens have a approach as far as what folks want to do and not do. So quality does matter. And it really depends on symptoms. So know that there are options for you and your loved ones with serious and chronic medical conditions. Not choices, but there are options. Just because we can do dialysis doesn't mean we should. If you're 92 and have terminal cancer, probably starting dialysis and putting you through that doesn't make a lot of sense. For others, it might. Talk to your priest. If you have questions about this, what should I do? What shouldn't I do? If I turn mom's ventilator off, am I killing her? Okay? Those are pretty heavy-duty questions. That's where your priest can help out immensely. Okay? So lean on them. Ask for palliative medicine. We're working on docs to become better communicators, to listen a little bit better. If you don't feel like your docs or specialists are listening, ask for a palliative medicine consult if you have one at your hospital. Okay? We can help with some of those talking points. Get your advanced directives done. Does everyone have their advanced directives done? Who has them done? Several. Good. Get them done. They're free. Okay? You don't have to go to the lawyer. Talk to your family about your wishes. Again, this is a huge gift, so they don't have to worry about this. And I don't know how many times I've had family meetings where we talk to a really distraught family who's upset because their mom just had a stroke. Then to talk about what do you think she'd want in this circumstance, and they look at each other and say, I don't know. It never came up. We don't know. A situation like that is so tough. It's always tough here. If it's tough up here because you don't know what they want or don't want, that makes it really difficult, okay? So please talk to your family. Let the hospital know at the time of admission that you want your parish notified, okay? They don't automatically let your parish know, right?
Huge, yeah. I mean, a parish of this size, you would think that we have a list of 20, 30 people in the hospital at one time. Sometimes we go to the hospital and they say there's nobody there. And then we hear later on, I was in the hospital and no one from church came to visit. So it's really important that you ask.
Because of privacy laws that's supposed to help protect people, it's actually kind of hurt in a lot of different ways. So you have to let the hospital know, I want my parish notified. You have to give them permission, okay? For some folks, it's very, very important. The spiritual health is as important as the physical health, okay? So let them know. Ask your doctor questions. This is not the Marcus Welby era where we always have to listen to Dr. Welby tell you what to do when you trust Dr. Welby completely. Still trust your doctors, but ask questions. It's okay. So ask your doctor, what is my prognosis? How long can I live with this condition? What am I going to look like a year from now, 5 years from now, 10 years from now? Okay? Now, they might not be able to tell you exactly, and you're going to get some hemming and hawing of, well, it kind of depends, and maybe if your treatment you're going to hear some of that, because it's really hard to predict. But ask, do you think I'm going to be alive in 5 years from now, Doc? No, I don't think you will. That's a long time. Okay, good to know. How will my illness affect my function? Again, function is huge. If you start if you have a stroke, ask about, well, do you think I'm going to walk again? Well, will I be able to talk again? Okay? It's all about function. What other treatment options are there? I heard about the chemo, I heard about the transplants and things. I'm not too interested in that. What other options do I have? Oh, yeah, we have quite a few other options, but those are the most aggressive ones. Well, I don't want those. I want something a little bit more in between. At what point should I consider a more comfort approach to my care? If you trust your doc or your nurses enough, they'll let you know. I think we're to that point. We've done everything we possibly can. Any further treatment at this point is only going to harm you. Okay, good. I want you to let me know. It's hard for docs to do that. Okay? They're afraid that folks are going to lose hope, give up. So it's kind of hard so they always want to offer something. It's as hard for docs as it is for patients sometimes. You can ask them, can you help me complete an advance directive? I don't have one. Can you help me get one done, or do you have the paperwork for it? Ask your doctor about would a palliative medicine physician be helpful for me to make decisions, to discuss goals of care. They might jump all over that, saying, oh, good, then I don't have to do it. Or they might say, no, let's sit down and talk about it now. I just never had an opportunity. And then can we just discuss resuscitation? So I went over a lot of different things, okay? Not to confuse things, but just to let you know that we don't always know what's going on. We do a pretty good job. Medicine's amazing these days. We don't know everything. We don't know how folks are going to do. We don't know how someone with pancreatic cancer is going to all of a sudden survive, and we see things that don't make sense to us all the time. So ask questions, know their options, get those advance directives done. Okay? So questions? Yes.
Our focus, your focus really, as it should be, is on the patient. What is available as options for the family, particularly as to respite care, as to palliative care? I know it's usually available at hospitals.
So the question is it's good to know what's open for family members. So more of a respite care for the hospice patients and things like that.
Or palliative is available for palliative care. Is that
as far as caring for the loved one to give the family a break, or
yes.
okay. So, unfortunately, a lot of what happens isn't because it's the right thing to do. It's based on payment and insurance and things like that. So it's really only in hospice where families can get a 5-day break per 90 days, called respite, where the loved one can go and kind of hang out at the hospice facility for 5 days while the family kind of gets a break. Unfortunately, we don't really have that for usual care or palliative care type programs. Now, there's always caregivers and folks that you can find, but they usually pay caregivers to help out.
Because certainly with dementia and palliative care, that could be a real issue.
It's a huge issue, and you kind of mentioned what dementia specifically. The caregiver burnout, spouse burnout is huge. And you can imagine having a loved one that's a little forgetful. So you're always afraid they're going to get up and fall and break their hip, or leave the stove on, or wander, or do something like that. I don't know how family members sleep at all. Always awake, always alert, and if there's just one of them, then that's a huge burden on caregivers. So burnout is huge. So recognize that in yourself, saying, okay, I need a break, or I need some help, or it's worth hiring a caregiver, or boy, mom's so forgetful now, I can't take care of her all the time. Maybe a daycare during the day is an option. That's where our fantastic social workers will help. Or the community folks can help, saying, hey, these are the resources that are out there. Good question. What other questions? Yes?
It seems like euthanasia is getting more of a social acceptance. And we've had instances where people have come to you and said that they would like that as an option. And I've had a relative talk about it. And it's like, what do I say to this person? I know it's a lot along the church side. Society seems to give into it.
Yeah. So the question is more about euthanasia and really more actually about physician-assisted suicide is what we've been hearing a lot lately because of things in the news. Have I had patients that have asked about that? Yeah. I used to live on the West Coast where you saw it a little bit more. Usually when folks ask saying, hey, just give me enough medicine so I can die. Or I hear all the time, well, we wouldn't treat our dogs like this. We would just put them to sleep and that'd be it. Usually when folks say, I want something to die, or can you give me something to die? It's really more of a cry for help than anything else. I haven't been listened to. No one's really talked to me. My pain is so out of control, I don't want to live like this. So as you focus on some of those specific issues and treat the pain a little bit better, all of a sudden life is not so bad anymore. It's not great, you're not in their shoes, but all of a sudden it's not so bad. But you're right, we're seeing it in the news all the time. And unfortunately, there's not a counter voice saying, yeah, we don't really agree in that physician-assisted suicide stuff, at least from a Catholic perspective. But you see it a lot in the press these days. The argument you'll hear from folks is that, well, it's a patient's choice. And they can die when they want to die. It's a dignity issue. They should die how they want to die and when they want to die so that bad things don't happen down the road. And I get that. I understand that. But this is something I do every day, all day, is taking care of folks that are sometimes upstream, but a lot of them that are dying. And there's so many different ways that we can help folks out. Yes.
What do you recommend for people that have advanced directives and are going to be traveling away from home with people, travel companions are not family members? Do you suggest they carry something in their wallet or on their person that would indicate to an emergency room that there are advanced directives on file somewhere?
So the question is if you are traveling with maybe not a spouse or a family member that knows what you want or don't want, how can you let other folks know what you want? And so you really can't, they have pocket-sized advanced directives, and this is my decision maker, this is their phone number and things like that, or you can keep in your wallet. Sometimes it does make sense just to carry a copy of your advanced directive in your purse or in the car someplace, or just pack it just in case. The issue with advanced directives, and it's more of a silly legal issue, is what's valid and legal in the state of Wisconsin may not be legal in South Dakota. But if you roll into an emergency department in South Dakota and have an advanced directive with you, or have some sort of do not resuscitate bracelet on your wrist, more times than not, they're going to look at that and pay attention to that and hopefully honor that. Or at least if they have some sort of document where they can call your decision maker, your power of attorney, they can tell them really quickly because they have that phone number right there what to do and not to do. But carrying something like that is a great idea. And making sure that you have your advanced directive scanned so your doctor has it, so the hospital has it, so they can always contact that hospital as well. Yes?
Are there places where you can get small things to
So the advanced directives I showed, there's a specific page where you can just cut it out and write the information down. And most of them have that. Yes?
You mentioned before about respite care and hospice. For 5 days, no monetary.
So based on the Medicare hospice benefit, you're allowed, and I believe it's 5 days per what they call recertification period, where that's part of your Medicare benefit, where your loved one can go to the hospice facility for 3, 4, 5 days or whatever it is. You can take care of what you need to do or get away for whatever time you have, and they completely take care of everything. That's part of the benefit. After that, it's back to the other situation. So if you were at home before that, you go back home. If things worsen for some reason during the respite period of time where you have to be in a hospice facility, then you can just stay there. So does Medicare take care of room and board charges, basically? Under the Medicare benefit, hospice will always be covered for your medications, for the nurse's care, for the equipment, okay? It'll cover the nurses coming to see you, the social worker, the bath aides, the chaplain, okay? That's all part of the hospice benefit. What the Medicare benefit may not pay for is room and board charges. They may not pay for rent, okay? So let's say someone decides kind of earlier on in the dementia or their cancer. I don't want to go to the hospital, I want to be comfortable for whatever time I have left. Okay. If you fit the 6 months or less kind of criteria, you can be on hospice. However, heaven forbid, you can still walk and talk, and your pain isn't so bad, and you're still kind of functional. Medicare will not pay for room and board at a hospice facility. They won't pay for room and board at a nursing home, necessarily. Okay? For folks that are dying like in a matter of days, or their pain is so bad that they need medication through the IV to control their symptoms, then Medicare will pay for room and board, will pay for you to be at a hospice facility or at a nursing home with hospice, but not just regular room and board. Does that help? Doesn't make sense sometimes, but it's kind of how it is. Yes?
Is there a gap?
They mentioned it briefly, and now at the hour of our death, they promote it. I think it's a good thing. If you can help save another's life by giving an organ, they're fine with that, generally. Would you agree? Yes.
Organ donors still alive. You're in tough shape, but still alive.
I don't know all the ins and outs, but depending on the type of organ, heart or lung, usually what we'll see is someone that's either comatose or on a ventilator. And they basically wait till the moment that you truly die, and then they do the transplant or remove those organs, so it's still going to work. So in essence, you might be still alive, or I don't know if they officially wait till your heart stops, you stop breathing, or whatever it is. But they have to keep the organs as fresh as possible. So I don't know what their official rules are for that, but your concern is that you don't want to take. Yes. So almost as this suicide by taking a beating heart out. I can check for you, but I think they wait till the moment like when your heart stops. It's a good question. Yes. Hi. So the difference between hospice at a hospice facility and hospice at home. So hospice is a Medicare benefit, not just for Medicare folks, it's for other churches too, but we think about it mostly for Medicare. So again, Medicare hospice benefit will provide all those services wherever you are. So nurse, social worker, chaplain, all those things wherever you are. So if it's at home, they'll provide hospice at home. If you're at a long-term care facility, because you can't get around very well, they'll provide that long-term care facility because that's your home. Versus, do you have a hospice house? Yes. So not every community has one. They're wonderful if you have it, just because you truly have experts in pain and symptoms and things like that in a facility. So if you're sick enough where you need to be at a hospice facility, and usually they're for sicker folks. Sometimes it is more long-term care, but usually it's for sicker folks. That's the best place to go. Hospice in a nursing home or a nursing facility, a long-term care facility, is a little different. You still have the nurses there that are always there to pass the meds and things like that. Hospice will only go to that facility once or twice a week or so. Okay, kind of like it would be at home. So they're not there every single day, whereas if you're at a hospice facility, a hospice house, they're there 24/7 every single day. Okay? Other questions? Yes.
Oh, is there an age limit for the organ donation?
I don't think so. I mean, we hear cases all the time. Some tragic case where some child, gets into a terrible, terrible accident, but they're able to pass their organs to somebody else to promote life. Well, sometimes it kind of depends on tissue things, but yeah, even as younger children, they can. It's my understanding. Yes.
What are the ethics involved as far as someone, say I'm 98 years old.
Yes.
I fall, break a hip. You know, and I know that I'm not going to survive the surgery, but on the other hand, are you going to let me lay there with a broken hip, broken nose? I mean, I could last another year.
Mm-hmm.
How do you make decisions like that?
I wait for Dr. Rapenchik to come tomorrow night, and I say, what would you do in this case? Ask him tomorrow. It really comes to the conversations and the discussions, and they're tough. If this is somebody that, and honestly, a lot of times they come up where the patient can't talk to us. They're too confused or whatever it is. So then it's even tougher because the families have to do it. But it all goes back to function. If this is somebody that was walking around, maybe slowly, but using a walker and getting around, and without fixing the hip, they're going to be stuck in bed for probably the rest of their life. That's a huge change function. Versus someone that's been pretty much bedbound anyway, well, fixing the hip is probably not going to change much. We can always treat pain. Always treat pain. And for someone that's been bedbound, doesn't get out very much, is really confused, maybe putting a splint on of some sort and making sure we immobilize the hip as much as possible. And use pain medication makes the most sense because putting them through a surgery doesn't make sense for them. So there's cases like that where we say, nah, the surgery's too risky, their heart and lungs are too bad, they could die on the table, and I don't think it's going to help very much. So therefore, that treatment doesn't make sense for them. Their goal should really be more pain control with medication. But as I mentioned before, we have hospice patients. They have 6 months to live with their cancer diagnosis. They fall and break a hip because the bone is bad for cancer, let's say. Where we say, wow, we could still get a couple good months for you. If we fix the hip, it's a pretty basic surgery, your heart's not that bad. I think we should go for it. There's some risk, but the benefit is you can still be functional. Your goals were to get up and play with those grandkids. Having the surgery will help you fulfill those goals. But those are tough discussions and decisions, and that's where we need the surgeon to say, how risky is this surgery? How simple is this? Do you think it's going to work? And does it make sense? Usually we can come to a pretty good conclusion when we sit down and talk about all those things. You're welcome. Great question. Yes?
Going back to when you said that someone had dementia, and they had, pretty small, and their goods, and then there was that, and he was dead, and he was there, like, this was and what can you do if it happens, at what time, you just not feeling, and what could you do?
Great question. And actually, I didn't talk about feeding tubes. That's part of the dementia part, so thank you very much. Was that on the slide? I forgot to mention. Thank you. So the question is, what about someone that has dementia? And honestly, for some folks, they'll say, listen, I saw Aunt Lucy with dementia, and she had aspiration pneumonia all the time, and I don't ever want a feeding tube, and really, if I have to keep coming back to the hospital a bunch, that's not how I want to live. You can put that in a document, or at least tell your decision maker, I don't want to be like Aunt Lucy, okay? Where they can kind of make that decision of, okay, it's the third admission, let's not do this again. This is really where setting those limits can help family members. Again, especially if you can't answer these things. Now, remember that the surrogate decision maker, the power of attorney, that part only comes into place if you can't make your own decisions, okay? So if you're in a coma, if your memory is really bad, or you have a stroke where you can't really function up here, that's when we activate the power of attorney. That's where that decision maker makes decisions for you based on your wishes, okay? So that's why we have to be clear about our wishes. So you might say, boy, I saw Aunt Lucy with that feeding tube, and they started with a tube in her nose, and she hated that, and they finally put that feeding tube in the stomach, and they fed her through there, and she pulled that out twice, and she never liked it, and she ended up having to be restrained and tied down. I don't want to go out that way. That's not how I want to live. I don't want a feeding tube. You can be very specific with folks saying, these are limits. I don't want this. And it's our job to figure out what else to do. So in a case like that, if someone's swallowing is getting worse, if they're getting weaker with their swallowing muscles, and we know this is going to be a problem again and again, maybe the best thing we can do, because we do want to offer them something to eat or drink. So remember, ordinary means give things because that's what we should be doing. But if they're choking on things or they're going down the wrong tubes, then it might become extraordinary. So if they say no feeding tubes, but we don't want them to starve to death, well, then you try to do things as safely as possible. You make sure they're sitting up. Make sure they're wide awake. Maybe water goes down too quickly, so we have to thicken things. So pudding texture and things like that. Folks can swallow that a little bit easier. So we try to be as safe as possible, take our time encouraging them to eat, but warn family members, this might not be enough. There might not be enough calories in 2 puddings a day, where they might get weaker and weaker over time. They might sleep more and more, and eventually they might die. Not because we're starving them to death, not because of your decision, but because the dementia has gotten so bad that they can't swallow and get enough calories on their own. Okay?
What if there was no breakfast?
if there's no directive, if you weren't kind to your family, that's how, is that kind of, if for whatever reason you weren't able to put on a piece of paper what you wanted, or you couldn't tell the family members, that's when you sit down with family members and say, hey, what do you think? Did mom ever say anything about a situation like this? And somebody might say, yeah, actually a couple of years ago we did talk about this. Or we were watching Law and Order once and it was on TV. Okay? So it might help a little bit. Unfortunately, if there's no direction at all from the patient, then we have to talk to family members and say, well, this is what we think is going to happen. This is going to happen again and again, based on what you know about your mom and her goals and what she wants and not want, and based on how she's been doing the last couple of months. You know, where do we go from here, knowing this is what we can do and can't do, and this is what might happen. We just try to make the best decision possible. When I have those discussions with folks, if I kind of see them hemming and hawing and I don't know, well, then we just keep doing what we're doing. We're not to that point of saying, let's stop things. That's okay. Maybe next time we will, or the time after that. It's whatever makes sense. Well, those are really tough. There's not a right or wrong way of doing things. Brilliant. Yes. So the question is should we be updating our advanced directives? Absolutely. It's not a one and done thing. Get it done now. Pick who you want for a decision maker. 5 years from now, I might pick somebody else. I don't like that person anymore. I want to pick my brother. Right. And your spouse might have died. Did you know that, at least in the state of Wisconsin, if you pick your spouse to be your decision maker and you get a divorce, that document is null and void. It's automatically null and void. You can't go to number 2 or number 3.
That's a good one.
But your comment is a great one, which again, this is a document. Your healthcare changes over time. You might, in an ideal, perfect world, everyone starting from the age of 18 will at least get a power of attorney document done. So heaven forbid I'm in a skateboarding accident, something happens, I'm going to pick my mom to make decisions. Great, have it done. Ideally, maybe after the age of 50, every year, hey, Mr. Jones, great that you turned 50. Because you turn 50, you get to do a colonoscopy, and we get to do all these tests. And by the way, it's time to update your advanced directive. I see you've been doing it every year since you're 18. Is there anything different on here? So that'd be ideal. So on a regular basis after 50, probably yearly, if there's a change in condition, if you're young and healthy at 50, but 50 and a half, all of a sudden, heaven forbid, you have a huge heart attack, we should talk about that again. Hey, last year we talked about your advanced directives and code status and things like that. You said you wanted to be a full code. You just had a huge heart attack. Has that changed at all? Do you think differently about the code status? No, still want to be full code. You know, they fixed my heart. They put some new blood vessels in there. I'm good to go. All right. So on a regular basis, change of condition, absolutely. That's partly our job. We should be asking that every time somebody comes into the hospital, every single time. And the primary care doc should be asking this on a regular basis too. In part, again, it's not about the document, it's about that conversation. Well, why ask me about advanced directives? I'm not dying. Well, no, but just in case we need to talk about things. Oh, good. So thank you. Yes?
Can you see a palliative care doctor before you're ill?
Do you see a palliative care doctor before you're ill?
In other words, you're getting out of the
Yeah.
Have you consulted before?
Sure, you can. So you could see a palliative care doctor before you get sick or before you get ill. Ideally, this is where you see your primary care doc that's been seeing you for 20 years and say, hey doc, what do I need to know about the future? Okay? If they have the time, which is tough because they're seeing so many patients back to back to back. And if they have the skill level to have these conversations and say, well, tell me how things have been the last 5 years or last couple of months and things like that, they should be able to do those things, and I would expect them to. And at some point, they'll all have enough training where they will be able to. If that's not happening and you have some questions about things like that, absolutely you could see a palliative care doc.
or a palliative care nurse practitioner, or a social worker. Absolutely. That might be where you talk to your priest too. I'm getting on an age, what things do I need to know from the non-medical stuff? Could be going around, right? Other questions? Yes.
Before your primary care doctor, you got one between 3.5 and 5 minutes.
Yeah. Give or take.
So if you sit down and talk about this stuff, how do you do this? Make 6 appointments in a row?
So how do you talk to your primary care doctor who has 3.5 to 5 minutes to talk to you about things? And this is one of those, as a recovering family physician, we always kind of dreaded I'm here for my cough and my lumbago's really kicking in a little bit, and this trick knee thing. Okay, we'll do these days. Okay, we're all done. Good to see you. Oh, by the way, when you talk about advanced directives, it's always when you have your hand on the door. So primary care docs, just because of time constraints, have a tough time with that. But by all means to say, hey, I'm here to talk about my runny nose and my back pain today, I really think we should talk about goals of care. I think we really need to talk about advanced directives. Can I make an appointment to come back and talk about that specifically? Absolutely you should. And even though I said ideally, when you come in for your yearly physical, they talk about this. It's a lot of time-consuming stuff. It's really important to talk about colonoscopies and mammograms and immunizations and your blood tests and recent blood tests that you had last year and things like that. To add the advanced care planning or advanced directives on top of that might be tough. But to ask the question, they might say, oh, I'm glad you asked about at least advanced directives. Our social worker, we'd love to start the conversation today, or make an appointment to start with them, and then we'll do a follow-up appointment in 2 weeks. We'll go over that. Absolutely, you should ask for that. But you're right, it's kind of hard in 4 minutes to do all that.
This is your special.
You can make an appointment to talk to me about advanced directives and things. Honestly, I'd be happy to talk to you. I'd probably refer you to somebody else that does this all the time and is hopefully available a little closer to you. So again, there's social workers that do this all the time. There's a fantastic program in the state of Wisconsin called Honoring Choices Wisconsin. I don't know if that's here yet or not. It's through the Wisconsin Medical Society, and they have trained folks just to do advanced directives. Wonderful program, first of its kind in the United States, where they're going statewide, where they're helping folks just with the advanced directive part, okay? So hopefully if they don't have it here, they have it nearby where you can do that. If you don't have that, ask your doc, and they might have resources as far as social workers, some hospice agencies, even though you're not doing hospice, would be happy to help fill out paperwork. From there, if it's kind of, hey, what's going on with my heart, and when should I talk to you about this, that's where your doc can do that. We can always help too. We're happy to. I don't know if you have palliative medicine folks. You do, good. So you do have somebody, but honestly, we're always willing to do this stuff. There's not a lot of us around. I wish there was. But there's just not enough of us to do this for everybody. So that's why we're trying to teach as many primary care docs as we can. So get those directives done. Ask lots of questions. Ask for the priest, okay? Good. Thank you.